Welcome. I am Roxana Parra Sepulveda, and today I have the pleasure to be with Dr. Felicity Zulueta. We will be talking about her new book, Healing the Fractured Mind. Felicity has gracefully accepted to have this interview so we can talk about what this book brings into the world of psychotherapy, and also talk about a little bit of the theory that is basing all the information that she will share with us today. I want to introduce you all Dr. Felicity Zulueta. She is an emeritus consultant psychiatrist in psychotherapy at the South London and mostly NHS Trust, and an honorary senior lecturer in traumatic studies at King's College London. She is co-founder of the International Attachment Network with Mario Marrone and other people. She developed and headed both the Department of Psychotherapy at Charing Cross Hospital and the Traumatic Stress Service in the Moseley Hospital, which specializes in the treatment of people suffering from complex post-traumatic stress disorder. She has trained in psychoanalytic psychotherapy, systemic family therapy, group analysis, EMDR, and lifespan integration. She has published papers on the subject of bilingualism and post-traumatic stress disorder from an attachment perspective, and is author of her first book, From Pain to Violence, The Traumatic Roots of Destructiveness, that was on a second edition in 2006. Her recent book is Healing the Fractured Mind, a revolutionary method for treating addictions and other disorders, published by Karnak in 2024. So, Felicity, thank you so very much for being here. I'm really pleased to see you. Welcome.
Thank you. I'm delighted to have the pleasure of speaking to you about this book, and it will be very, very interesting for me too.
Yes, and we have the book here. I just want to take it closer so everybody can see the front of this book, which I personally found incredibly easy to read and a great fund of information and theory, and very easily and clearly explained. So thank you for that as well, because I think it will be very helpful for people that are not necessarily a part of the psychotherapy groups and psychotherapy world, but also social workers and other professionals that can benefit from understanding what, for example, complex traumatic stress disorder is, and so on.
Yes, it was written with the idea that the interested, curious layperson would enjoy it too. I think that might be a little hard at the middle, but with the elephants and the animals that I bring into the subject, I think it makes it a lot easier. It reminds us also that we are actually animals as well, which I think we try to forget.
Yes,
we are mammals.
definitely.
We are mammals.
Yes. It shows how, how humanity is portrayed so clearly, and the needs that we have as well for connection and love in life. No? So, do you want to tell us about this book? What motivated you to write this book?
Well, actually, I was ordered to write this book 25 years ago.
Okay.
And it persisted because the person who ordered me to do it kept on saying, "When are you going to write?" And actually, this person she was present at my book launch, and she is a normal person living in society. But when I met her, it took her on for treatment for the diagnosis of borderline personality disorder, which now is UPD. However, I just quickly point out that means it's still a personality disorder, which is not correct. We think people who suffer from this say it's related to trauma, and it is. So this young woman, I saw her for 4 years. They were quite difficult years, as these treatments are. Very fraught at times, upsetting at times, but we navigated through this journey. Twice she left me, which is feeling much better. Everything appeared well, to be going well. She had friends, she had a degree, she had all these things. And yet twice she had to come back. And this is very typical. And when she came back, she said to me, I really don't understand, Felicity, she said, because I have changed everything in my life. And I've got a new job. I've got this degree in law. I have new friends. I get on very well with my family. And why do I want to, what really struck me, she said, why do I want to destroy myself in the same way as before I started treatment 4 years ago? And that's pretty heavy. And I thought, fortunately, we will find out later why, I had learned something new when I saw her in this situation. So I said to her, this was an assessment interview, which we did in a private sector, so that she wouldn't get back into the whole atmosphere of the national health and so on. And I said, I'd like you to actually tell me a bit, what about your mother? Oh, she changed tone. Oh, my mother, she doesn't appreciate what I've achieved. Oh, I said, okay. Well, I wonder, I said, if you'd mind doing a little test that I've learned recently to do, which might be very helpful for you and me. And she said yes. We had a very good relation. So she said yes. And so I said, well, imagine, then I said to her, imagine now, there's a chair in front of you, look at that chair, and I'm going to ask you to say certain words. But first of all, imagine that your mother is sitting in that chair, and you must notice what happens in your body as you say the words that I'm going to tell you. And she then said these words, which I will tell you because they are an important part of our work. And she said, Mum, I had what I did first, which was what we do, is to ask somebody who's coming into therapy, for therapy, to ask them as an adult person how old they are and what they've achieved in their life as an adult. So I said to her, and she had told me, and so I said, tell your mother's opposite you, and you say to her, Mum, I'm now a grown-up woman with a job and a career before me. I don't need your approval as I did when I was little. There was a long silence, and then she swore. And she said, oh, gosh, yes, I haven't resolved that with Mum. So to cut it short, I prescribed her a morning ritual, which I had learnt running a group for women, and then who had been sexually abused. And it was a group that I ran according to an American man that was a very successful group. It was a 1-year group only. And in this group, the man who wrote this book, which I followed because I was desperate to have treatment for these patients, and we had a lot of specialists. So he said to have this ritual where the person chooses a day in which they're going to mourn the loss of their little self, which is actually what I've asked this young woman to do. I have said, you've had this view of Mum that you've rather idealized by thinking that one day she could actually, instead of being the terribly difficult and horribly upsetting mother, she could one day turn around and become nice and give you what you want and the love and the appreciation. So that's what I'd asked her to do. And that is why it was so difficult. Her body said no way. She felt it in her throat, in her chest, her heart rate goes up, everything. The thing only lasts 2 minutes, but it's enough to awaken all these somatic memories of early experiences that this child's self has experienced. And so she went off and she did this ritual, and we had a session before Christmas, which she said, I haven't actually managed to do it yet, but I'm going to do it, don't worry. And then after Christmas, she came in looking splendiferous. Really, she was wonderful. And she said, I've done it. I've done it. And then she said, and you know what? I'm normal. And I thought, yes, there's a bit of idealization going on here. I'm normal. I'm not having any more of these feelings, thoughts, and ideas. I'm just a sort of what I imagine is a normal person. I said, well, that's wonderful. That's wonderful. And then I followed her up, of course. And she had a life, a normal life. She turned out to be gay, and then she got married to a woman, and she had a baby, which was arranged with a father figure who was still involved in reality with the family. And the boy has grown up now, because we're now 25 years away from that. Mm. And she's done this law degree, but she wants to work with children to help them between the school and parents, so that they are not forgotten like she was and never got the help they needed. So she's in the middle of doing all that. She's grieved the loss of her father. And at each of these occasions, knowing that my patients who have this diagnosis usually break down at these points when there's a loss of attachment. And she didn't break down, and she mourned it. She was able to mourn. This is the thing. But she describes in the book, she's written part of the book, and she describes the mourning, and it was extremely painful, extremely painful. So the more disturbed these individuals have been by the more traumas they've endured, the more big is the loss, and the loss has to be acknowledged and worked through. Anyway, she came back, as I said, at the end of these 3 sessions extra, we'd done a completely different person. But before she left me, she said these words, which I think I have to tell you, which is why I wrote the book in the end. She said, she stood up, faced me and said, "It is now my turn to tell you something that you need to do." It was an order. "You must write about the way in which you enabled me to live as a normal person." She advised me to use this we call it the Traumatic Attachment Induction Procedure, but which is an experience, an assessment of other patients with similar histories of abuse, since it was so valuable for her in achieving full recovery. So that is why. However, I took my time for many reasons. The fact is that, as she said before leaving me, she said, and another, I warn you, she said, your colleagues will laugh at you. They will not take you seriously. She was well aware that this would cause resistance. How can it be that this woman in a psychotherapeutic setting can actually achieve this? No, it's not possible. And of course, the fact is that the person who gave me the knowledge to be able to develop this TAIP, we'll call it TAIP, shall we? Actually had a very hard time as a result. So he suffered a lot because he did it in the prison system, and he successfully treated a homicidal man. And one sees it, I saw it on a panorama in video. And 27 years ago, that's how I had this idea. And I was flabbergasted, because over these sessions, they had 1 session and then 2, and then a third, the last. This homicidal man, who was absolutely rigid and terrified at the thought of facing his mother, imaginary mother, because she had beaten him up as a kid, this man was relaxed. And when the doctor said, "And now imagine your mother there, what would you do?" He said, "Oh, that's not a problem, doctor. I would just lift my hand and say, 'Mum, I'm an adult now. You can't beat me. It's been. But of course, if you want me to leave your home, it's your home, and I will go.'" Perfectly, normal, civilized man.
Yes.
But that led to disaster. Yes, for the whole unit and for him. And my colleagues and the medical establishment were very bad and nasty. Fortunately, this man is now a professor, and he's called Professor Bob Johnson. And I am so pleased he was part of the happy result of the book, and he checked my book and he's happy with what we've written.
Fantastic. Yeah, because there are so many different points of inspiration. This order that your patient gave you, and then also the work of Professor Bob Johnson. And that also makes me think about the other aspects, the other elements that are then becoming the foundation of what we are calling TAIP is. And so can you explain us a little bit and introduce us into the notion of what is the traumatic attachment and how does it develop?
Yes. Well, it's important to state that the traumatic attachment is really part of one's learning about attachment theory and research. Because Alan Shaw, who is a man who's written and spoken about it very, very often and who's a wonderful teacher, he described it very clearly in his work. And basically, but before going to describe his work and going into more detail, it's been ignored really since then. It's been theoretically proposed, but not actually in any way. Nobody's thought about using it in this context. So what happened was that what enabled me to actually give even more weight to the TAIP was the fact of what I learned in writing the book, which was that mammals all develop. Mammals have all appear to have, many species definitely, perhaps all, perhaps not all, but most species appear to have this capacity, this traumatic attachment can develop when the mother fails in her capacity to look after, protect, and care for her young. Mother Nature seems to have enabled them. So what happens is, let's think of Harlow's monkeys, which most people have heard of. There were these poor little monkeys, young monkeys, who had not had any mothering for 6 months. And then they were precipitated into a situation where they were made advances by some perfectly developed male, these were female monkeys, and the male monkeys, of course, wanted to have sex. And these females were not at all interested. So they were artificially inseminated and then had babies. So the young babies were born to mothers who had never been mothered. And they became what was called monster mothers because some of them were so aggressive. They bit their babies, they killed their babies. They kept on pushing them out. The baby would cling on to the monkey, cling on for dear life, literally, on their backs, trying to get underneath to get the nipple. And the mothers refused, but after a certain amount of time, a few of them made it to the nipple and survived. And interestingly, after that, when the mothers then had babies later on, they became better mothers and they were able to mother. So that's interesting. So that's in them. And then I was even more surprised when I read about the rats, baby rats. And here the researchers actually used the strange situation developed by Mary Ainsworth and used by Maine, which I will talk about later because I'll explain. So the strange situation was designed, well, I better talk about it now. And the strange situation was designed for to assess, once Bowlby had come out with these theories of attachment and the necessity for mothering for children from early, right from the beginning of life, and the nurturing and the looking after, the caring, the attunement, all the things that require for a child to become able to be secure and to live a life which they can enjoy and so on. Well, in all for these tests, Mary Ainsworth devised this test, which was a separation test where you can find it on video.
Yes.
Where the baby is with the mother and then comes a stranger and so on. But basically, it sums it up. What they look at is, after the second separation from the mother, how does the child interact, these 1-year-olds, with their mother? And whereas a secure child is pretty upset the second time, but when she takes up the little kid, the child calms down quite quickly. Love. But the disorganized one, which is what we're talking about, the traumatized one, the disorganized or traumatized infants, they don't settle down. In fact, strange things happen. Some of them go towards the parents, some of them go and then suddenly turn away, others collapse on the ground, others just disconnect and just stuck in there, and so on. That was the main and Hess's experiments. And actually, they're quite horrific to watch. And that is still being used in order to assess whether the babies, these infants were traumatically attached, traumatized. And so that is this, and they used it in a simplified form with their pups. But first of all, what they did is they had to traumatize some mummy rats. And to do that, what they did was they took away, they didn't give them enough fodder to make a proper nest. So the poor mum has these pups, and then her instincts say, you must make a nest, a proper nest, a proper nest. So she climbs over these pups in this urge to get some stuff to make this nest. And of course, she hurts them at that point. And of course, the feeding session is interrupted. They still get enough food, but it's interrupted. And these pups, when they're separated from this mum, they hang on for dear life, just like Harlow's monkeys. They have a traumatic attachment to mum, which they maintain for the rest of their life. And even for her smell, that is there. And the interesting thing about all these mammal experiments is that they found that in the mammals, in adolescence, when these mammals reach adolescence, they show similar behavioral disorders to our children when they reach adolescence, having been traumatized. By the way, I just should add that the strange situation with the disorganized children is not just for children who were abused physically or neglected, but also for children whose mothers were grieving at the time. And when in grief, mothers are not able to be available in the way that they need to be. So that meant that we actually, with service with the traumatized people in the TSS, as we call it, Traumatic Stress Service, we always put these mothers of babies who were traumatized, we put them first on the top of the list to get them treated as soon as possible so that their children wouldn't suffer. And they had to be put in care while the mothers were. And the other thing is that the mother, when you think of the mummy rat, you also think of the fact that that's what our women and men in this country are being subjected to, and in other countries in the States too. They are being deprived of the time and the possibility of really caring for their infants in the way that they would like to, because they have to do 2 jobs, because they have to run out and go and get food for the family. So what are we doing? There's social implications.
Yeah, massive social implications and massive questions as well for the type of life we live, how available, how the pressures of our daily life can actually make us be emotionally available for our children. There is very important questions all around there. And
so coming back to your question, the initial one, if I may, do you want me to?
Yeah.
Is the fact that so that is what I saw was Bob Johnson was doing. He didn't know that at the time, but that's what he was doing. He was doing a strange separation test, an imaginary one with an imaginary mother, but it had an extremely powerful effect, because basically what he was eliciting was this template, the internal working model of the child who was desperate for mother or terrified, but in either case, you are attached, traumatically attached. And that was it was had been dissociated. That's why it was unconscious, dissociated away in order for an idealized attachment that makes up for the traumatic attachment, which is carried out by the rat. They have an idealized attachment that enables them, when they emerge from the disconnected state, when they, like you heard, these children in the Mary Main study, they disconnected totally, but then they had to reconnect with mum at some point, or with father, because otherwise they wouldn't live. So they have this imaginary idealized attachment, but that means that the imaginary one has to be at the cost of dissociating, keeping out of consciousness all the horrors that they have experienced. And that's why the self, that's why I call the book, is called The Healing the Traumatic, the Fractured Self, because that's the point when the self is fractured. And then there is enough now, though people are not aware, the researchers in neurobiology are not at all aware of this, and I don't know how they'll respond to it. But the fact is that they have more and more studies showing that the children who have been traumatized in early life have an abnormal development of different kinds. And this is what we see, and that's what's expressed in adolescence.
And the core here is that element between the role that dissociation will play to keep you alive and the need of connection, those two elements that creates the fragmentation, the fracture of the self, right?
So the strange situation elicits it, which is what the TAIP does. And we can go into that when you look into what is the TAIP.
Yes, we will continue to talking about this. In what we are talking here, it makes me think as well about the ACEs report, the ACEs studies, and how that also is linking the childhood early difficult experiences, no, with the development of psychopathology, but also of so many other issues with our physical health, right?
That's the bit that we haven't done anything, and I'm just hoping some brave people are going to start doing some therapeutic, doing a TAIP with physical. Yes, the ACEs is, I'm glad it is beginning to be taken seriously in England. You know, the psychiatric establishment in the States don't acknowledge its reality.
Yes.
As they don't acknowledge also the existence of complex PTSD. The DSM-5 will not want it, doesn't want it. And I think it's big pharma. Big Pharma says there's no money to be got about this. And anyway, if it's all one diagnosis, it's only one piece of money. And if we have multiple diagnoses, we get lots more money. I'm afraid that's the situation. But anyway, in the UK, it's not yet there, hopefully. And the ACEs was a wonderful study. Felicity, whom I've worked with, whom I've met, and we did a work together. He was in this Kaiser Permanente unit, which is very well developed medical establishment where they do very good assessments and so on of their physical patients. And he had a weight reducing clinic, and he was very surprised because many of the women who came to this clinic would they said they wanted to lose lots and lots of weight. But then when they got near to the point where they were reaching their aim, supposed aim, they would pull out and disappear. So he couldn't understand that. So he thought, I must interview these people. So he got hold of them. He gives an example of the first woman. And he asked her, he actually made a mistake in the way he asked it. And so she heard him saying, what age were you when you first had sexual intercourse? Which is not what he was trying to get at that particular time. And she said, 4. And he said, what did you weigh? And she said 40 pounds or something like that. And he was horrified. And he said, but really? And he saw that it was a reality. And he, like me, in his medical training, had never heard of the fact of sexual abuse. And even in my psychotherapy training in the Maudsley, and when I started, which is now many, many, many years ago, I was told that it was all an invention of the patients. Believe it or not, yes. And so he then decided that he did more things and found out about more horrors, violence, abuse, and sexual abuse. And he decided it might be him that's asking the wrong questions or something. So he got his team and they all did it. And they found an amazing number of very distressing childhood experiences behind these people's symptoms. So then he got a guy called Anda, who worked out a research project, 17,000 people, more than that. And they had all their medical histories already perfectly. And they just looked at how many of these adverse childhood experiences, that's what they called it, these experiences had been part of their lives. And they found that the more of these there were, the more physical conditions like heart attacks, many of the main illnesses in the States and in the UK have an enormous component, at least, due to this vulnerability. But nobody is thinking of that when they give these dietary and medical things. And so that's very, very interesting. But he himself didn't actually know about the traumatic attachment. What I did when I finished my work at the Traumatic Stress Service, I retired because basically it was becoming impossible because they were trying to cut everything and I could no longer see refugees because that was not on and so on. So I developed heart palpitations and I decided that my health was not good. I didn't want to sacrifice my health like many of my poor colleagues. And I left and so on. But then, of course, I wanted to do something. So I was teaching, but I also, every time I gave a talk or a conference, I invited anybody in the audience who wanted to do this research on the TAIP, which I presented. And several people joined me and we formed a group and we've been carrying out this group for several years. And they bring videos and we've developed the TAIP and we have the videos and we look at how they do, how to do it better, what needs to be added, so on and so on. And the result is that we found that we have patients who respond very well and become normal, dare I say, with unresolved grief, addictions, alcohol and other, with complex PTSD. I discovered that in the Traumatic Stress Service. You've heard about the homicidal. I haven't treated homicidal patients, but I've done the TAIP and it's fascinating because they are all like this Bob Johnson's patient. They've had terrible traumas in childhood. And we're just carrying on, and it's random because these people are doing private therapy.
Yes.
And so it's who turns up at their clinic. And of course, that's why we're very keen that more people start doing it, and it's done in other centers and places. Yeah.
That's interesting. We will talk a little bit more about that, but before we go ahead with that, why don't you tell us a little bit more in detail, what is the Traumatic Attachment Induction Procedure, the TAIP, so people can start to understand what the procedure is, and we take it from there too, because there are so many elements, no, that we are looking at in terms of the theoretical base with attachment theory, with the ACEs studies, with the understanding of how traumatic attachment is formed as well. So there is a lot of material there, and we can think about the impact not only of traumatic experiences but also loss, abandonment, and other kind of lack of emotional containment and connection in early childhood.
Yeah.
So interesting. So why don't you tell us a little bit more about
the actual TAIP?
Yes, please.
What it involves. Well, it's based on this, on Alan Shaw's view that there is at some point in the child's development, mum has not been available, and the child has had to resort internally to
Yes.
developing an idealized attachment, but that is being disconnected by dissociation. So these patients will all have some degree of dissociation. And the more trauma, the more they will have had dissociation. So that's one thing. So we pick them up by things like one of the characteristics of attachment, if you think about it, is if you're going to idealize your parent and your parent is telling you that you're really bad and you're horrible and so on, you then have to identify with that, because otherwise it doesn't make sense. So to keep, and in that identification, there is control, the possibility of being in control. I decide what to do with my life so that I can make my mother, or make me love. So there is that. So it's become it's called a moral defense. Fairbairn developed that idea, and all our clients, patients, by the way, patients. I use the word patients because I worked in a hospital, but I really use it still, because the word patience comes from patire, which is to suffer in Latin. And the word client makes me think of going shopping and buying things. And I do not think that people with traumas should be identified with shoppers, because they are not looking for things. They want help, and they've been lacking in love and care. So that's why I stick to my patients.
Yes, and I will endeavor to do the same while we're talking.
No, but it's just because other people use clients, and most of my group use clients. It's okay.
Yes, or service users. I mean, depending on the context that I have been working, different people use different language, and I've always liked understanding that you have of the word patient, no? And it makes a lot of sense for the work that we're doing.
But I know it makes me a doctor, and doctors are not very favored for these various reasons of how badly they've been doing with psychiatric cases.
No, but there is a debate about this concept. There is a debate. We will not get there because we are
we can't do that.
Focus on wanting to share with people about TAIP, but I think it's important as well to mention, if you don't mind, this common element of dissociation then becomes a central part of the work that we are talking about here.
It's very central, and actually, unfortunately, it's very muddled, the definitions, muddled and difficult for people to get. And we're finding difficulties in finding a form. We use the dissociation evaluation scale, which is quite good in some cases, but not in others. So then you have to use another one for somatic dissociation, because when it's all in the body and not in the behavior, so on. So there's a little difficulty there, but I've read many papers now on dissociation in mental health, and more, and they're using DES, so that's for good. And the other thing is that we learned that it is a normal, natural process. Okay, but we'll come back to that. But that is what made me feel I can write the book, because what was I doing? What were we doing to make is dissociation a pathological thing? Then how come it can disappear? How can somebody be suddenly different and be normal?
But if you want to, or to make it clear, if you want to explain what you want to say about dissociation, and then we go to TAIP, because that will help as well to understand.
Help. It is a natural phenomenon. And then you say, how can it be a natural phenomenon? Well, that's why I started with elephants in the book. I was involved, and this is another reason why I came up with the book, because I was involved. I was asked one day from an American reporter in the United States, said, "Excuse me, do you think that elephants can suffer from PTSD?" And I then thought back and thought, yes, actually, my parents happened to have a baby elephant when I lived in Africa. And my mother looked after it beautifully. It lived in the garage with an antelope and the dog. And this little baby elephant loved my mother, had lost his mother, and mother fed him, and she was very good with animals. And then they realized that soon he would be bigger than the garage, and the garden wasn't big enough for the poor little elephant to survive. So they thought, what the hell are we going to do? And so they thought, of course, we'll send it to the zoo. And the little elephant went to the zoo and died because it had been able to use my mother as a second mother, but no, it didn't have the care and love it needs. So I said to them, yes, I think, and actually since then people have identified and written a lot about PTS, traumatized elephants, and what they happen. And of course, they are violent. They can be very violent. And what I was invited to was to do a film with Geographic, which was about these elephants, young elephants, teenage elephants that were in the jungle. It had been imported into one of these artificial parks. A lot of people in South Africa are buying big estates, and then they want to have a safari parks. So these little young ones were imported there. And when they reached adolescence, something was going wrong. And the man running the park, who's a nice chap, decided, well, what are we going to do? But surely what was happening was that rhinoceroses were being attacked and killed. By what? Nobody could work out. There was never any tusks removed, nothing, horns with the rhino.
Yeah.
So, and then a tourist did a video of one of these young elephants attacking a rhinoceros. So they realized that was the cause. They were even raping them as well. And so they decided, and then fortunately my colleagues in the States who are into elephants must have been asked about help. And they said, bring in 2 male elephants into that park. And what we've discovered, the reason for this is that we hear then that these young elephants, they were chosen to go to the park because there was a moment in the Kruger Park when they had to kill a lot of elephants because it was being damaged by too many. So they shot the mothers, and these little youngsters were tied to the mother's leg and witnessed mother being turned into meat for the butchers, and were then carried in trucks, because in those days you could easily do that, but you couldn't take a whole elephant, a big one. So they took these young ones, and some were females, and they didn't have the same issues of violence, but they had others. And these young males then became like our adolescents who are not looked after in our streets. So these, they then, this man had these 2 elephants put to sleep in the Kruger Park and taken by trucks into this safari. And these youngsters, they come out all, trying to show how clever they are to these big papa elephants. But in a few days, everything's changed. They were measuring the testosterone, which, because they had a lot of this, I've forgotten what it's called, there's a gland that it secretes. Must. They were in full must at a much too early age and much too much. And they had high levels of testosterone in their poo. So this started to change. The poo became normalized for their age. And these elephants became normal elephants when they were no longer violent. The presence of these 2 chaps, and I think it was the fact that they also came from the same social actually made all the difference. And that is very interesting because it shows that if you're a member of a group, social group, and your mother for some reason is killed or is depressed or can't deal with you or is ill, then these youngsters have alternative parents, grandparents, and this applies to people in tribes, tribal life. And I had that experience in Borneo, where I lived amongst headhunters for my father's malaria doctor. And they lived in their longhouse, and all these little kids and me. I had joined because he'd be busy doing his work and I was there. So I played with them and so on. And these children, if mummy had any problems, then there was granny, auntie, sister, and so on. And that's how nature, quite rightly, enabled that phenomenon to take place. So these kids are only disconnected for a while and then they connect. But in our society, with single parents or only little parents separated from communities, of course, these conditions then just fester. And that's why we're having a lot of these issues. And we are meant to be social animals and live in communities, not individualistic animals that have to rely on competition, which is what our current system is about.
Absolutely. Yeah, so important. And so these give us then the base.
Yes, so the
why don't we go then to talk about the traumatic attachment induction procedure?
As it's used in psychotherapy.
Yes, as it's used in psychotherapy.
So the therapist will have a patient and then takes a story and then gets this message that this individual has been in therapy before and keeps on leaving therapy or just has lots of therapy and it doesn't work. And this person has a very idealized view of a parent who doesn't sound very ideal, or a very negative, a black and white, one parent very good, one parent very bad. It's a bit unreal. And they also have the moral defense. In other words, they think of themselves as extremely bad and so on. So they then think this is probably a traumatic attachment. So then they will be in therapy with the individual. And at a certain point in time, the issue of the relationship with the parent may come up. The relationship is good, has to be good, tuned, I call it, and tuned, compassionate, which involves mentalization and attunement, and that it has to be a good relationship where your patient, your client patient feels safe with you. And then you say, you know that we've just been talking about the difficulties with mum, and I wondered if it would be a good idea to do a little exercise, or they call it experience, to do an experience together, which may actually be very helpful to you and to us in therapy. And if the person shows an interest, you say, well, before that, we do interview with a video. We do have a video recording of this because that enables us. I am part of a group, says the therapist, who are studying this new way of working. And we find it very helpful if we can then share the videos. It can make us improve our work. It can make us understand what's going on and so on. And also, many people who've had it done like to see it or like to even keep it because it gives them something that they really can make use of and making understanding why they're going through troubles and what's been going on. So most individuals at that point trust the therapist. If they trust, they say yes, and they sign a form for the video. I always added, of course, if you change your mind after the video and you don't want it, we just destroy it, okay? And it won't be shown in other places except within our group, or if it's for teaching exercise, we might come back to you and ask for approval. So that's how we set it up. And then comes the moment when clearly that it would be appropriate from what has been said and what is going on in the treatment. So then at that point, we want to make sure that there's an adult in the room.
How do you do that?
Well, first of all, you said, let's go back to just how old were you when you now? How old are you now? And remind me what you've done, in your life, what achievements you've done. So you get the person to focus on that. And then you can write it down for yourself. But then you're going to say, now I'm going to ask you to do something, and I want you to repeat some words after me. And while you do repeat those words, I want you to notice very much what's happening in your body. That's what's so important.
Important, right? Yeah, okay.
So then I may remind the person, the therapist may either, can you tell now, imagine your mother is in the room. She's sitting in the chair opposite you. Do you imagine? Now I also want you to realize that you are now going to share with her what you've shared with me. And you may have to prompt the person.
Sure.
Say, I'm 40 years old, I'm a teacher, I have 2 children, I have done this, I love writing books or whatever it is. And then you say, and now could you just say and notice what happens in your body? Say to your mum, as you talk to her, say, Mum, I don't need to be frightened of you anymore, or I don't need you anymore like I did when I was little. And that is when they struggle, and the struggle begins, and the body goes, I don't want to do this.
No.
And the heart goes, the throat, and the whole is terror. Terror is the word, but
yes,
much less than when you were tiny, but it's there. And you say the therapist then is aware that there is both an adult on the one hand and a child on the other. And the therapist has to address both in a way. Hold the adult so they don't feel humiliated. For instance, with my patient that I mentioned who I said, I will look away so that you don't feel embarrassed. But I didn't stop doing that because it didn't seem relevant. So that's one thing. And the other one is to help that adult understand what's going on. So you say,
yes.
Are there any thoughts and memories that come up for you as you feel these? Have you been there before? Have you felt these feelings before? And gradually what can happen then is that they say, oh, that's how I felt with Mum. God, that's just how I felt with Mum. Say, yes, but now you're an adult. You're no longer, so you're not a little fellow who's going to be hurt by her. So what can you now say to her? I don't need you to be frightened anymore. So you help them do that. So what you're doing is I call it the triangle of love. You are enabling the adult to become conscious of the little self that was dissociated off. The little internal working model, which is a word for template, of me in relation to a frightening mother is come into the room. And me, the idealizing person, there's no need to idealize because actually I'm the adult. And this is me when I was little. Doesn't need to be frightened. I'm perfectly capable of it. And it's that you work. And sometimes therapists will go back and do it again and so on. So we all have developed ways of doing, but that is the same essential thing. And if you don't keep the adult in the room, if you suddenly notice they're going back, you stop and you carry back to the beginning. Because what can happen then becomes another form of therapy, a sort of gestalt, which is not what you want. What you want is the adult becoming consciously aware of the presence of the little self that went through hell. And as they do that, the dissociation melts.
Yes.
Compassion, loving care, attunement, all these things are the ingredients to enable the dissociation to disappear, like the papa elephants and the young ones.
So a dissociation that was useful and was needed to maintain some sort of equilibrium and balance within is no longer needed. And the person can function from an adult self, recognizing their capacities as well, right?
That is happening, but there's grief at the same time. And the grief is happening because that was rather nice to have the hope that she would love me one day. That was so nice to think that I could have that care that I never had. And that's when you really, then we need to have a grief. That's why I send my patient to do that little ritual.
Yes.
And what happens in our therapeutic step is we don't have sometimes not really mentioned it, but it's happened because the therapies are short-lived, not very long, and the therapist is at that point aware, and the patient is aware that they don't need any more therapy, but
yes.
there is working through the loss of the therapist. And of course, in analytic work, that is also the loss of the transference of the idealized person and so on. So you're doing both at the same time. But in people who have had more severe traumas, you have to actually work on the grief. And in fact, I think one should always remember that, very important.
Yeah. Especially is like the bereavement of the parents or the mother or the father that you didn't have.
Yes, and it's really very difficult. I mean, I'll just read a few words from my Claire. She said, I remember lying in bed with gut-wrenching pain of crying so forcefully I thought I'd drown. It consumed my whole body. Waves of feelings would jolt out of me. Probably for my self-preservation, I don't remember what I did after that. But the same, and then she said I had a similar pain starting exactly the same place in my solar plexus when years later I left my baby son for the first time with a friend. So it's interesting. And she said I had a sense of emptiness, a tight and urgent pull to go back. I had to overcome that, and so on. So this is why the borderline patient is so-called EUPD for what I actually call it traumatic attachment disorder. That's what it is. That's the label I would give to some. Anyway, these people have suffered so much that there is a lot of loss to go through. There's so many hopes unfulfilled.
Yes, and Judith Herman talks a lot about the fact that with trauma there is loss.
Yes.
It goes together, goes hand in hand.
And Sandy Bloom has written something beautiful, but I'm afraid I can't remember the title, but it's about that terrible loss.
Okay, and if you remember, we can mention it later as well. All right, so we have now clarity on what the procedure is.
Yes.
Can you tell us about how it can be used? Because you also written the book with other people have contributed to some chapters of this book, members of the group that you mentioned, that research group. And so do you think TAIP can be complementary to diverse approaches in psychotherapy?
Yes, I think it can, because it is in itself a procedure, which can be, you can adapt the therapy to the procedure and the procedure to the therapy, basically. So long as you maintain the adults and the infants and the triangle, you have to keep that. But if you do that, then you could have it. And in fact, there's great interest in from EMDR people in actually integrating it. And I think that's what I hope to see, is people using EMDR. And
for those that have no knowledge or understanding of EMDR, would it be usable as well?
Yes, yes. So that's for the EMDR. The people that have participated, my 3 co-authors, were using psychoanalytic psychotherapy, and use the psychoanalytic, but she also used lifespan integration. And so I think it can certainly be used, but it needs to be worked through. Yes, one has to work through. And hopefully, yes. One thing it doesn't seem, from my experience, we're now training people. We've trained a few groups in Spain and in England. And I've noticed that the people who've just done cognitive style therapy, CBT and so on, and not had any experience using attachment research theory in their work, find it very difficult. They want a very line-by-line protocol. But actually, once you get the gist of what you're trying to achieve,
Yes.
you can modify it to suit that particular person and your own therapeutic habits and so on.
So the knowledge of what I'm hearing is that the knowledge and understanding of the attachment theory is an important element for being able to apply TAIP.
And also makes you realize you're doing something that's valid.
Yes.
Because otherwise, somebody said, well, it's like EMDR. Well, EMDR is a fascinating thing. It works, but nobody quite knows totally why it works. I mean, I have my theories why it works, because it was this finger wagging, which actually I found is the best treatment for trauma that we have. And but it actually, and what I think is the reason is that it crosses the corpus callosum in the finger moving, and that is where a lot of dissociation is kept maintained by blocking of the corpus callosum. So that may be one factor that's very important. Yeah,
that's interesting.
But nobody quite knows.
No, nobody quite knows.
Whereas this, when you ask about research, my hope one day, just quickly there, is that one day some researchers with brain scans, and Van der Kolk, who wrote The
Body Keeps the Score,
and who was my teacher of trauma, he did brain scans and discovered that when the patient is reliving a trauma, their left brain shuts down, the speech area shuts down, and their right brain becomes hyperactive. And that explains mutism, which can happen with children who are traumatized, but also it can happen in your work, in sessions with patients who've been traumatized. And I had a young woman who became mute in an assessment, and I was didn't quite know what the hell to do. But I just instinctively just went on babbling. Babbling on about how I felt she might be frightened, something might be happening, perhaps she'll be able to tell me at some point, blah, blah, blah. And she then, in the next session, said to me, that was so helpful that you went on talking, because I could hear you, but I couldn't speak. My speech area was gone shut. So, and that's what you don't want to cause. And of course, that is what happens when you trigger a trauma. And I've always worried, and I was good that I practiced it in a trauma service, because I was always worried that this tape might trigger such traumatized, and traumas can be terribly long. People can then have hours of it. It's very, very scary if it's severe. And no, never have I, never, nobody has been triggered by this response. On the contrary, yeah.
So it comes as a solution to dissolve the dissociation and help the integration of the self, support the grief after trauma. And it sounds to me that it's a very a powerful tool to produce that post-trauma growth that I call it. No,
it's very important. The thing is that I was teaching some people working in the prison system, and they were telling, and I know because I'm a member of the International Attachment Network for Forensic Psychotherapy, and I know that they do a lot of work trying to get prisoners who've been violent to feel grief and remorse. What we're discovering, and I think it's rather relevant, is that you cannot grieve if you haven't got a whole self. That's what unresolved grief is about. And once you can eliminate the dissociation, then they can grieve. Yeah.
Yes.
So I think that's probably part of the reason why there's a wish not to know much about this, because it does imply quite a lot of different approaches.
Yes, and we are reaching the end of our conversation. You have told us about the research group, the hopes that you have for the research group. Is there a way that if people are interested in training in TAIP, is there what they can do if they are interested in training? Is that something that we can tell them something about today?
Yes. You have to give them an email.
Okay, we can add this information
Yes.
on the description of
Yes.
this video, so you don't have to go in detail with that, but they can then contact you or the team through the email that we will be sharing.
Give an email. I'll have to ask which of my colleagues wants to take on that.
Yeah.
We are running, Monique Notice is actually participating with me in a training that is taking place on the weekend of the 21st and 22nd of June.
I see.
And anybody who applies for that can come. It's a 1.5 days, 2 sessions on the Saturday and 1 session on the Sunday, with video illustrations given by my colleagues of actual tapes being carried out. And I give all the research.
That's great. So to finish, in the front of your book, it says, Healing the Fractured Mind, a revolutionary method for treating addiction and other disorders. What do you think about the use of the word revolutionary method?
I have to say that I was shocked. I had nothing to do with that. It was my publisher who put it there. But actually, I think she's onto something, because as we've been talking, what I've been really emphasizing, this is a procedure used in research. And here we are using it in psychotherapy and yet it has the same capacity to induce the traumatic attachment as it did in the strange situation, as it did with the baby rats. They did it in a strange situation in a different way. And it is obviously works as such. So it is the introduction into psychotherapy, as we know it, is an introduction of a research method. And I hope one day somebody will do a brain scan of somebody actually doing it and seeing what's happening in that brain at that point in which they actually are enabled to say, I don't need you anymore. And that would be fascinating, because the thing is, does the brain then, it must change if the behavior has changed. The thing that is missing, and this is interesting, we have a lot of wonderful neurobiology, but I've never seen anything on the neurobiology of dissociation.
Okay, a good call there then for anybody that is listening that may be interested in starting to think about this. Some research. What's going on in the brain when dissociation is present? That's a wonderful question. Do you feel there is anything that we have missed that you want to say before we finish? Any message that you would like to share as part of probably the message of your book? I don't know. Is there anything, Felicity, that you would like to add before we finish?
I don't think so. I mean, I could have spent some more time talking about the difference between the strange situation and ours, and how the strange situation actually is a much more frightening experience for little ones, lasts a much longer, 20 minutes, and actually is putting that child in. Whereas in the room, it's a therapist who is involved in your care, who is trustworthy, who is helping you last 2 minutes the first time, and then it's the patient who asks for it to last longer, and you go along with it. It's under the control of the client, and if they decide they don't want it, it's in their hands. So, and then most of them are saying, so thank you, and we've never had a complaint. So I would love to have many more therapists taking this up, because we need many more. At the moment,
Yes, indeed.
we've got 6 with 2 new ones, 8, and we need a lot more, and in Spain too, which is where
Yes,
it's been published.
definitely. And we need to then have a look as well, because the book will be eventually published in Spanish as well. Is that any advance around that?
In September, probably.
In September, probably. So the invitation is out for everybody that wants to know more and read in detail about this procedure, the important work that you have done around this, Felicity. We invite them to read the book. And for those that speak Spanish, be alert, because the book also will be coming out in September. And I just want to say a big, massive thank you. It's an honor for me to be able to have this conversation with you, Felicity, and to be able to make it happen. So thank you so very much for everything.
Thank you so much for inviting me. For me, it's been a great honor too. And I really enjoyed sharing my work with you and with other people. It's a lovely work, and it's lovely. It's so healing for the therapist too.
Yes. Okay. Thank you so very much.
Ciao.
Ciao, ciao.
Ciao.